So at the outset, let me thank the organizers for giving me this opportunity to interact with you all. I thank Dr. Sharmila Madam for a good introduction, and the chairperson, who is nobody but my wife. So this is for the first time I'm enjoying this kind of combination. Medico-legal aspects. I think this is quite important topic for all of us doctors. We at Pune have this organization, Core India Institute of Legal Medicine, which has a team of legally qualified doctors, and the executive board consists of renowned, well-known personalities. So without spending much time, let me come to our topic proper. Apart from the clinical outcome, we medical professionals nowadays have to worry about what is legal outcome. And you all will definitely agree with me that every patient has become potential litigant. Now, since the application of Consumer Protection Act to the medical field in 1995, there has been an increase in the cases being filed against the medical professionals. And it is said that more than 400% increase is there in the cases against medical professionals. Now, let us just view a video clip. आवाज
It's not lost, Doctor. Expression. It's not blood pressure, Doctor. Oh, 72 kg. That's right. I can't do a thing here. I don't know. She must throw it in with. She's getting mine or not. I'm gonna guess.
So the film, The Hospital from US, 1971, almost 47, 48 years ago. So this film, actually this is a shot from this film, in which the patient has been taken inside the operation theater and suffers from cardiac arrest, and then the anesthesiologist finds out that there is a mistaken identity and the patient does not belong to this surgeon. So this is just out of interest I have shown this. The actor was George Scott. He is the chief of the Manhattan Hospital. He is the chief of surgery. And there are a series of deaths which are unexplained. So this is quite interesting. I think you should go through that. Now let us come to our own topic. This is professional negligence. Now, are we professionally negligent whenever we are actually labeled as negligent? There have been a number of cases against all of us. Probably the criminal liability and civil liability is being discussed at length in the court of law. So what exactly is the scenario? Is the professional negligence is nothing but omission or commission of an act by medical professional that deviates from the accepted standards of the practice of the medical community. So this is in short the definition of the professional negligence. There are various approaches towards such kind of a professional negligence. They are either tort law or constitutional law, or a doctor may be charged under criminal law. Previously, Fatal Accidents Act used to be the act under which the medical professional used to be tried. Medical Council also many times labels the doctor negligent, and probably the cancellation of the registration is what we experience. And the Consumer Protection Act 1986, which was applied in 1995, is the one which actually is taking toll of doctors. I'm specifically using this kind of a word. How this negligence is actually discussed? There are 4 components basically. With various case laws, various judgments from the Supreme Court, the principles they have come out, that is, there exists a legal duty when we examine a patient. If there is a breach of this legal duty, and this breach causes injury leading to damage means either death or the disability to the patient, it is said that the medical negligence has taken place. There are certain settled principles. Probably you might have heard about them. One most important is the Bholaram Principle, 1957 in UK. You all are knowing that our all legal system is actually from or inherits from a UK's common law. Now, Bholaram Principle, this is a psychiatric patient, 65 years old male psychiatric patient who actually receives electroconvulsive therapy without using anesthesia, and the litigation that followed because of the patient suffered from a fracture, there were 2 sets of opinion, and then the Justice McNair, who had a problem of deciding whether the doctor did right or whether the doctor was wrong. The one set of opinion said that doctor was right, that he has used the accepted standards of practice, that is, he has not used anesthesia or the muscle relaxants, and the other set of opinion said that the doctor was wrong and he must have used the anesthesia. Justice McNair, he actually did a good thing for the medical professionals all over the world, and he came out with a judgment that if the doctor follows the accepted standards of practice, the standard might be as low as possible, there is no problem, but if he follows that, and if any one expert opinion is in favor of the doctor is not negligent. But then in 1997, there was another case, there was a Bolitho principle, which comes out with the Bolitho principle. Patrick Bolitho was a 2-year-old male child who was suffering from croup, that is a cough disorder. The lady pediatrician who was on duty was called at least 3 times for cough disorder of this patient, and patient was breathless. For 2 times, she witnesses that the baby was all right when she visited the patient, but 3rd time, the breathlessness lasted for longer time, and the baby actually suffered from cardiac arrest, though revived, baby went into vegetative state. The litigation that followed, again there were 2 sets of expert opinion. One said that the lady pediatrician should have actually attended the patient and intubated the patient so that this possible outcome could have been avoided. But the second set of opinion, expert opinion obviously, said that whatever she did was right. Judge Lord Brownie Wilkinson, he came out with a judgment that whenever there are 2 diametrically opposite opinions, it is not necessary for a judge to consider any opinion, and the principle which he set forth was logical analysis. So that means it is the discretion of a judge which will prevail, which will take over. And then after 1997, all over the world, this Bolitho principle was used to decide the cases against the medical professionals. And then what happened was, instead of Bholaram principle, Bolitho principle was used, and this is because of that in many of the cases, judges were discretion was used. In India also, the same principle is now being followed. I will be discussing about few judgments which affect anesthesiologists. There is no data available of the cases against cardiac anesthesiologists, but the cases against cardiac surgeons and the anesthesiologists that is available. So few of the judgments I'm going to tell the important aspects of these this thing. 1988, Kalavati versus State of Himachal Pradesh. This was a criminal case against anesthesiologists. In this case, instead of oxygen, the anesthesiologist used nitrous oxide. Of course, it was an accident, but then patient died. The anesthesiologist was actually labeled as criminally liable. Kulwinder Kaur versus Dr. Kiranpreet Kaur, Makkar and others. 1997, it was from State Commission's, Punjab State Commission's decision. Here, meningitis followed by lumbar puncture. So, the anesthesiologist could actually prove that the strict asepsis was actually followed, and it was not the negligence by the anesthesiologist. Fortunately, there was no negligence as such. Then Dr. P. Narasimha Rao versus G. Jayaprakash, 1990. This was a case of tonsillectomy where the oxygen cylinder was empty and the oxygen was not used. And what happened was, again, there was cerebral anoxia, and that particular patient was in the vegetative state. And it is here both surgeon as well as the anesthesiologist were labeled negligent. Arunaben Kothari versus Nandadeep Clinic, 1996, Gujarat State Commission's judgment. Negligence was due to not acting on pre-anesthesia report. That means there were some changes, certain changes depicting that the patient was having chronic ischemia of the heart. So on this, it was proved that the anesthesiologist didn't arrange for the defibrillator. And here the anesthesiologist was labeled as negligent and had to pay the fine or compensation. Then Rashmi Fadnavis versus Mumbai Grahak Panchayat and others. This was National Commission's case, 1996. Now in this case, National Commission said that anesthesiologist is equally liable as that of the surgeon, though the anesthesiologist is not directly hired by the patient. Next judgment is Lakshmanan Prakash versus State. That is, this is again a criminal case, 2001. Here, failure to check during pre-anesthetic checkup. So, whether the patient will withstand drug dose or not. And what happened was 3 ml of the local anesthetic was given while through the lumbar puncture, and the patient suffered from the cardiac arrest and patient died. So here, the anesthesiologist may be criminally as well as civil negligence may be liable. So this judgment was given. Now one of the judgment from West, that is Hepworth versus Kerr, 1995, it was mentioned that duty of anesthesiologist to provide safe anesthesia as well as follow established evidence-based practical guidelines. So this is what way back in 1995 in this judgment it was mentioned. Now coming to certain discussion about the risk in the anesthesia. Usually while giving anesthesia there are certain points where the injuries can take place, that is there might be dental injuries, airway management may be associated with the injuries, there may be poor ventilation, esophageal intubation may be there, or many times the difficult intubation is there. So the anesthesiologist must be prepared to tackle complex problems that require speedy evaluation, quick prioritization and immediate intervention. These three terms are quite important. Usually it is said that there is a implied contract between the patient and the doctor. What is the meaning of implied? Implied means which is not written, and express means which is written and the consent has been sought. Though anesthesiologist directly doesn't come into contact with the patient, it is said that there is a doctor-patient relationship that definitely exists, and legally the anesthesiologist is liable. So anesthesiologist is equally liable as that of a surgeon. Consent. Nowadays, this principle, informed consent, has actually come into picture. Well, it was through the case law Samira Kohli versus Prabha Manichanda. In this case, the court has come out with the basic principles of informed consent. Means the doctor and the basically surgeon who is going to intervene the patient's body has to actually inform everything, all pros and cons, all complications must be explained to the patient, and then this must be recorded in writing. So the special consent must be taken. This is known as a informed consent, which should be legally valid, and it should be written consent. So it's the doctor's duty to explain all the procedure, specifically anesthetist's responsibility to explain all the risks involved. As far as possible, rather than experience, it is always better to explain on the basis of the statistical data. Any changes that might be required during the surgery must be explained, and there must be clear documentation. What is the meaning of evidence-based practice? Now, if we consider the principles, basic settled principles, along with the informed consent, it is proper documentation is very important. So it is said that you document, but if you don't do anything, it is taken as you have done. But then if you speak so many things that I have done this, I have done that, etc., etc., but if you don't document, in the legal eyes, it is taken that you have not done anything. So proper documentation is most important, and usually it is the evidence-based practice if you follow, that is accepted standards of practice if you follow, that holds good in the court of law. What is evidence-based practice? It is conscientious, explicit and judicious use of current best evidence in making decisions about individual patients. So this definition was given by Kakade et al. In 1996. Why it is important? It is important because this holds good in the court of law. There are certain levels of evidences. So how these levels of evidences are actually discussed? It depends on, rather than my experience, so rather than experience based, if it is proved on the scientific basis, on the basis of various randomized trials, it is considered as a level 1 evidence. Level 2 is less important. Level 3, 1, 2, 3, they are less important, and level 4 is on the basis of the experience which is gathered by the surgeon or the anesthesiologist. So level 1 evidence is far more important in the court of law. Now this is from our Kaplan's cardiac anesthesia. There are 4 particular errors which we have to actually prevent and take care of. I'll just go through them. Errors that are involving the placement of central catheters, intraoperative awareness, drug errors, and effects of the TE on the vigilance. So these are the under 4 important headings this is being discussed. Now this is from Kaplan's. I think you have gone through this. Reducing the error from the use of central venous catheters. This is quite important. There are certain guidelines which are given, that is, one has to use sterile barrier precautions. Ultrasound guidance must be used. Pressure waveform monitoring or manometry to avoid cannulation of an artery. Tip of the central catheter should be outside the heart. Chest radiograph should be there to confirm. And we have to consider use of antibiotic impregnated CVP catheters. So this is from the Kaplan's. Second is avoiding intraoperative awareness. This is quite important. I think this is being discussed in various conferences also. This definitely creates problems with the patient, and patient suffers from various complications in the post-operative period. So though the overall complication rate is less in all other anesthesia practices, in case of cardiac anesthesia it is more, that is about 0.4% to 1%. Now this severity of intraoperative awareness experiences varies from mild to profound. Some patients experience post-traumatic stress disorder. Evidence says that the use of computerized ECG monitoring, which is quite important, EEG monitoring, which is important, and the limitation and artifacts which are encountered must be actually monitored. Now this is reducing the errors related to the drug administration. Drug errors are quite common, and it is common at the hands of perfusionists. The suggestions are barcoding should be used. Then barcoding must be approved by FDA. error reduction systems which are available with infusion pumps, and the perfusionists administer drugs during cardiopulmonary bypass should be included in error reduction strategies. Now, it is said that use of transesophageal echocardiography sometimes distracts the actual focus on the surgery and the monitoring of the patient. So, with the permission of the chairman, I will take just 2 minutes. So here, the operation room logistics is quite important, and that must be actually taken care by. Certain key points which need to be discussed, evidence-based recommendations which are quite important. In case of the central catheters, the tip of the catheter must not lie in the ventricle and atrium, because that produces the cardiac tamponade, which must be avoided. Reliable method of the inadvertent cannulation. Of course, we have discussed about this, that use of sonography and the manometry. Reported risk must be avoided. Then errors in the drug administration there must be self-reporting studies which must be actually discussed. And anecdotal means experience-based evidence that says that the error reduction systems are available that must be used. The last point, the American Society of Anesthesiologists, this is the study which is available where the cardiac anesthesiologist claims were discussed. Highest claim, 327 claims were actually, which was 3% of the total claims in US and in that particular study. Now I would just tell you about brief of my PhD study. That is, I analyzed 350 cases where I came with certain conclusions that nowadays the patient is not looking at us as God, but patient has developed a consumer attitude, and shopping attitude is there. What is happening is, it's because the litigation process is quite easy and simple, the number of cases they are being increased, the time taken for judgments is more than 6 to 8 years, and the medical professional is looked as a service provider and not as a god. The overall perception is that the medical professionals are the soft targets, which must be made soft targets. And regarding the basic principle of the deciding cases, as I have already mentioned, it is the Bolitho principle which is being used, where the judge has his discretion. Approach to the compensation, there are so many case laws. If you have heard about Kunal Saha's case, it is now the punitive approach, that is a punishing approach, is being used by the various judgments, where the higher number of compensations are being awarded. Now what should be done? What should be done by us? We have to unite. It's good that we have a good association. The most important thing is that we should not criticize each other, because this is the one which actually instigates the litigation. Codification of standards, that is same as evidence-based medicine, that must be actually created. Perfect documentation, valid informed consent, educating our staff, and offering the patients the arbitration, that is alternate dispute resolution, is most important. Regularly updating ourselves is quite important. Now, prevention of errors by proper precautions, seeking medico-legal help is most important, and this is quite important. Now, though I have tried myself to contain to certain particular topic, it's a huge and vast topic. We may discuss this topic for a day or two. I have just come to interact with you for this particular very important subject, that is a medico-legal implications. I think I have tried my level to talk to you, just introduce this particular subject. With this, let me come to end of my talk. I thank you all for patient hearing, and I thank the chairperson for allowing me to speak more 2 to 3 minutes more. Thank you very much.